So we've got about 15 minutes for questions from the mics, if we could. And the organizers have asked me to contribute to the decline of Western civilization by asking if there are any questions from Twitter. I got Amy Berman at the back of the room with the mic. And do I have Twitter questions? I have Twitter questions. Miss Berman.
Good morning, Dr. Morrison. We have a question from Diana Martins Welsh from Twitter. Her question, she works in palliative care oncology, and she's seeing more patients with legitimate pain from stage 4 cancer who have a history of opioid use disorder, some still struggling with substance abuse. Recommendations on how to handle this.
I'll pipe up for a moment. First of all, I want to draw attention that we have a speaker. Oh, it's not on. Check. Oh, it is. It just went on. Oh, good. This is why I can't get through Target. We have a speaker later today, Dr. Jessica Merlin. She's in the first row, and I think she's probably going to provide a lot of very specific clinical insight on this situation. The reality is we have lots of people who have ongoing addiction or in remission from addiction have dependencies who then develop cancer. The appropriate decisions that I engage in addition to calling people like Dr. Merlin, are individualized decisions. These sometimes involve a decision that opioids are needed, but an extremely close monitoring regimen, which involves not just me, but very knowledgeable nurses. Sometimes it involves a potentially off-label use, potentially labeled use of buprenorphine as a patch, or possibly off-label use of some of the products that are approved for opioid use disorder. Sometimes it's non-opioid treatment entirely. So I typically consult, I typically call friends, and whatever it is, if it's going to involve a controlled substance, everything is negotiated up front, a very explicit conversation with the patient, and often very frequent visits. That's sort of a gestalt, but I think Dr. Merlin will have this covered.
Let me go over to Professor Tulsky, and then we'll go back to Twitter.
Thanks, Tom. So earlier on, Dr. Lipschitz, when she gave her talk, spoke about how the substance use disorder problem and whatever opioid epidemic existed early on was primarily among minority communities. And now it's more among white rural communities, and suddenly we're hearing about it. Suddenly it's become an epidemic. And it's hard not to sort of feel that way, and I understand the numbers have spiked and so forth, but I guess this would be a question for Dr. Smith or perhaps anyone else on the panel who wishes to answer this. I mean, how much of the concern that's being driven now is actually another aspect of racial bias?
I think the audience is agreeing with you. Yes. Right? I mean, I think when this impacted the minority communities, the response was not that this was a public health crisis, but that this was a legal justice system crisis, and that laws had to be put in place to, put people who fell into this category in jail. It wasn't that, oh my gosh, this is an actual illness, and how do we address it and improve it? And so that absolutely plays a role into this, and I think it only leads to and increases the bias.
Yes, I'm going to the middle, then I'm going to the left.
Okay. Am I on? All right. Good morning. My name is Amy Melnick. I'm with the National Coalition for Hospice and Palliative Care, but I'm serving today with Amy Berman as responding to questions from Twitter. And so we have a question here from Jack Rossfeld. Dr. Rossfeld from Ohio wants to ask, specifically, this is directed to Dr. Kurtesh, in moving away from pill/OME counts, measuring what's easy, toward patient outcomes, measuring what matters, are there current policy demonstrations that are good, say the opposite of Oregon Medicaid's considering zero opioids?
Yes. There are measurement tools that are part of the process of figuring out who is at higher risk. The question is, what do you do when you identify somebody who, in quantitative estimates, is at high risk for an adverse outcome on opioids and who is receiving them? But as an example, I work in the Veterans Administration. I'm not here formally on behalf of the administration, but the STORM tool, I think it's Opioid Risk Mitigation Strategic Dashboard, essentially looks at the medical record, pulls all the diagnoses, and says, look, based on typical risk factors, which have been proven in VA data to predict both overdose and suicide, this patient's at higher risk. The next step is not proven to be protective of life. We don't have a trial, but is for a group of people who represent pharmacy, mental health, opioid dependence expertise, and palliative to talk about what might be helpful to risk mitigate. And very often, one of the key drivers of risk is untreated or unengaged mental health care that's needed. So we often follow up by saying, well, gee, not only have some questions about the medication regimen, perhaps it's not the optimum one, can we get this person engaged in care? I wish I could say to you that there's a large trial to prove that this is safe or that this actually generates safety. There is not. But that's kind of the sort of thing I see, and I also see commercial equivalents to that. But for the doctor out in primary care without a bunch of supporters, I actually think they're going to need mentorship and supports available to them remotely to advise them on those patients who often are troubling and challenging to deal with.
Marion.
Hello, I'm Marion Grant. I'm a policy consultant here in Washington, but I'm also an occasional palliative care nurse practitioner in Baltimore, which has been a heroin town for decades. We pride ourselves, we believe in the classics in Baltimore. And I am definitely seeing the pendulum swinging with clinicians being very reluctant to prescribe medication for patients who appropriately need them, these opioid drugs. I've had 2 cancer patients recently who were users. One went back to using street drugs. The other one was trying not to, but having a very hard time. And she had a fungating rectal wound. And I just want you to, there was no debate about whether that hurt, right? You just looked at it and you knew the woman was suffering. What can we, but her oncologist had said to her, I am not prescribing opioids because you have a substance use disorder. Even though when I called our substance use department, she was well known to them. She was highly compliant with her methadone program, so she was a good citizen. What efforts do you see, if any, that are I'm trying to hold the line on policy. I comment all the time about what I think are bad proposed rules. What can we do about clinician attitudes? Because I am seeing a clear just say no to prescribing opioids attitude amongst many of the wonderful clinicians I work with.
So my view is that those clinicians need a safe harbor. That safe harbor is not being offered to them. Yeah. And that it will probably require a very robust statement from a public authority, probably the CDC, the AMA, and other entities like that, saying, and maybe the DEA, saying, we intend to uphold and protect you in these situations. And I believe it may not be solvable without them receiving some sort of assurance. One of the things we notice in our own hospital, we have clinicians who are afraid. They each make independent judgments. We can't control them. I can't tell someone, don't stop opioids or do start them or whatever. That's not how it works. But we have consultative advice from people who are perceived as senior and people who are perceived as having expertise, who can then provide a little bit of a wing and say, you know, this was a tough situation. Your patient did get a prescription from another doctor for 2 days. We don't quite know why. Your patient did fail to have the opioid in their urine the day that you saw them. Here's what our suggestion would be, and we often make recommendations based around holding on to the relationship. There's only so much safe harbor that a professor or a senior doctor can provide. Ultimately, we will need insurers and officials to speak up.
Well, I was encouraged by the AMA's comment just recently where they're starting to push back and say, hey, this isn't, you're telling us how to practice medicine and that's what you're not supposed to be doing. But
more is coming.
And if I could just add to that quickly, is that as also a palliative care clinician, I will say this outright, I feel real comfortable managing pain and giving doses of opioids when they're needed, high doses. What I did not learn and what I am not as comfortable with is treating substance and opioid use disorder. I didn't learn it. I did not learn it. Whatever learning I now have has been in the form of, I've done the BUPE course, my 8 hours. Is that enough to make me an expert and to feel real confident and comfortable in treating that? Nope. I'm fortunate enough that I too have friends like Dr. Merlin who are experts, but that's not the vast majority of the clinicians that practice in this country. You mentioned that you have a substance use disorder clinic. Congrats.
They're my new best friends.
Yeah. And they are scarce and few and far between. And I have one in my own institution. Can't get my Medicaid patients in there. And so, it's a real issue. And when you talk about how do you, help encourage your clinicians, your other colleagues to prescribe, it's a bigger conversation, and that it's not just prescribing, but how do you do it safely? And where do you learn that? And where do you go?
Thank you so much for pointing out the earlier gap in our training program. I take back everything I said about you. Back to Twitter.
From Paul Tatum on Twitter. Dr. Tatum writes, hospice medical directors tell me that more doctors are refusing to fill opioids for hospice patients and want the medical director to take over prescribing. How can we convince primary care providers that they are the best prescribers?
Honestly, they might not be the best prescribers. We have to acknowledge that we have lacked the training in addiction, the training in dependence, and the training in pain. And so we approach this prescription decision in a way that's very different from how I would embark on dealing with anticoagulants for deep venous thrombosis, where every single year of medical school, I learned a different implication of the problem I was trying to treat. That said, we can't possibly send every single patient to the medical director of a hospice or a palliative care program. So we're going to have to offer a degree of support and training that is beyond merely alluding to a guideline or just one website, and it will have to be multiple supports. I think those doctors are clearly afraid, and I kind of spoke about how we address the fear factor, but that has to be complemented with an education factor and mentoring and help. I still ping people in the middle of the day by text message. I got a guy with a funny urine drug test result. What do I do? So you have to be able to ask questions.
Explicit. That question did not say a person with an opioid use disorder. That person specifically said that
palliative.
In general, they're having people who are asking to move to the medical director.
Implicit in my response is that the dependence that we see when we have people on long-term opioids has a spectrum of manifestations from absolutely benign to rather problematic to addiction. And it can be challenging to feel your way through the murkiness of it.
So Stephen talked about applying...
Could you introduce yourself, please? Sorry.
Oh, Salima Meghani from University of Pennsylvania. I'm also part of the committee, the planning committee. So Stephen, you talked about applying the adult guidelines to pediatric population. I would say that the CDC guidelines are of very low quality guidelines, as they indicate in their abstract of the JAMA publication. They're very low level guidelines, and they're widely adopted by states, payers, insurers, pharmacists, etc., as evidence-based. I think CDC has cast, or the federal agencies have cast, a blind eye to the misapplication of the CDC guidelines. So the first recommendation of the CDC guidelines is to use non-opioid, non-pharmacological agents as first-line treatment for pain. And we discussed that those are widely not available. The President's Opioid Commission report also talked about removing pain assessment from patient satisfaction survey, so just pretending that pain does not exist. So my question is, what can be done to increase the accountability on parts of the federal agencies and feds in general in terms of the consequences of the widely adaptation of the CDC guidelines?
I wish I had an answer for you. From the pediatric point of view, I think the beginning, the major mistake was, of course, that pediatric wasn't part of the beginning, because I think the guidelines would have looked very different if we would have been. And among that, we already heard from Stefan that clearly if you actually read them, they're actually not that terrible. I mean, many things are quite okay in pediatrics as well. The problem is there's like zero evidence in some cases. Some things what we not would do in pediatrics is that then insurance companies, drug plans, hospitals are picking this up, and they're quoting the CDC guidelines inappropriately. We just heard that, right? So it's basic up on us. The problem is there's no help, right? I have this patient right now in pain. What do I do? Yeah, I don't know every single chief medical officer, and I'm pretty well established, right? And I can basically go there, and I may be able to, like, with lots of work and lots of phone calls, to do one thing. But there's basically, this is kids. Right? We have our adult guidelines, and that's basically nothing we can do. Yeah, and it's basically kids are suffering. And what I hear from you, I'm surprised, because like the adults have it like so much better than children, that it actually it still stinks. So I hope that the outcome of this is that somebody in the room sort of sits here and said, all right, as a national institution, as the American Medical Association, as somebody from Blue Cross Blue Shield, as somebody from the Academies, it's like, all right, we have to do better. First of all, we've completely put a blind eye on 22% of our population, and that has to change, right? And the other 78% do not seem to be doing that well either.
So I am afraid we're going to have to close this session. I know there are people still at the mics, but I think we'll have some time later this afternoon. I just want to take a moment first to thank Dr. Leibschutz, who started off with really just a brilliant talk, and thank you very much for setting the tone of the day exactly as we wanted it to be set. To my colleagues from Mount Sinai who schlepped down here, Roseanne Leipzig and Ora Chaikin, thank you. And then my colleagues on the panel, my two Stefans and Cardi, thank you very much for really setting the day off correctly.
Let me just add my thanks to Sean for moderating the panel and all the panelists. And Dr. Merlin, the expectations are very high for you. But we're going to take a 15-minute break, and we're going to stay on time and end early as Leonard demands. And so please be back in the room. Actually, it's going to be a 12-minute break at 11:15. Thank you.